Also, we can use keratoprothesis. Keratoprothesis is a surgical method of treatment corneal opacities based on implantation of a keratoprothesis. It's a special device, artificial device, which put inside the cornea, except of the opacity. I have one question. How can I... One second.
Stop writing or what?
Как я могу проверить?
Будет так в чате и будет бриферить.
Stop talking, guys.
Yes, I try to... Василий Иванович, я пытаюсь просто понять, как я их могу проверить. Тут же есть тоже чат, да?
Конечно, они пишут свои фамилии. Вон чат внизу 13 человек. Видите, мелькает 13, 14.
Okay. Guys, you can write your names in the chat here, and from now till 4 p.m. please do it for 4 minutes. Then I will stop the checking your presence and we will continue our lecture. Okay, thank you. I see that you write your names. Thank you. And we continue our lecture.
Я их сейчас копирую и перешлю Светлане Владимировне.
Когда закончат, тогда печатать там через 4
минуты. Сколько минут? 4 минуты дали им?
Да, ну вот до 4 часов, да, ровно, чтобы у меня сейчас...
нет, пусть все, сейчас вот отметится и все, хватит.
Ну, до 4 уж, ладно, сказал, до 4.
Guys, only 3 minutes, that's all.
Guys, till 4 p.m. and then we'll stop the checking. Okay, the next part of the lecture is rather big too. It's about choroid. Choroid, I remember to you that it is a vascular membrane of the eyeball, and then the other name is uveal tract of the eye. It consists of 3 parts: the iris, the ciliary body, and the actual choroid. There are 4 variants of inflammation of the choroid. It names uveitis, and depending to the blood supply, it divides to anterior uveitis or iridocyclitis, intermediate uveitis or cyclitis, and posterior uveitis is choroiditis. And there is the 4th one is panuveitis, is inflammation of the entire uveal tract. Classification of the uveitis. Anatomical variant, it's anterior uveitis, intermediate and posterior and panuveitis, as we told in the previous slide. On the picture you can see the red light, anterior uveitis, the blue light is intermediate uveitis, and green light, it's posterior uveitis. It due to the anatomical parts of the choroid. Classification of the uveitis. Clinical variant. They can be acute, chronic, and recurrent. I think you understand this variants of classification. Due to etiology, it can be infectious and non-infectious. About infections, of course, it's bacteria, fungal, viral. Mostly it's herpetic variants of uveitis. Non-infectious, systemic. Of course, it's mostly due to the rheumatologist disease. It's arthritis, Behcet, sarcoidosis, and other different rheumatological diseases. Specific ocular variants, it's Fuchs heterochromic iridocyclitis and non-specific idiopathic iridocyclitis. There are 2 variants due to pathological classification. It's non-granulomatosis and granulomatosis uveitis. in non-granulomatosis 1, we can see small keratic precipitates. Precipitates. It means that there are little spots of pathological fluid on the back side of the cornea, on the endothelium. And granulomatosis uveitis, there are different variants of size of precipitates. It can be medium size. Please stop talking or switch off your microphones.
محمد صلاح طلق الميكروفون.
Я уже выключила, спасибо. Iris nodules, of course, and iris granuloma. Here you can see big granuloma of the iris with medium size of precipitates. Iridocyclitis. There are three types of iridocyclitis: toxic, allergic, metastatic, and traumatic. There are different signs of this process, and we speak about it too. But firstly, about etiology. Etiology is very different, very different. It can be viral, protozoan, bacterial. It's of course metabolic diseases and the diseases of teeth and organs of the nose and mouth. Also rheumatological diseases such as Behçet, Vogt, Koyanaki, Harada. Also eye injury can cause the iridocyclitis too, and some keratitis can cause iridocyclitis too. So it's very various. Complaints of acute iridocyclitis. It's severe pain in the eye, especially at the night. It's very specific. Also photophobia, lacrimation, blepharospasm, so corneal syndrome, decreased vision due to the process in pupil, and headache due to the severe pain in the eye. Clinical picture: pericorneal or mixed injection, change of the color and fused picture of the iris, contraction and deformation of the pupil, pure reaction to the light. About main signs of anterior uveitis. It's reduced visual acuity, circumcorneal congestion, keratic precipitates, anterior chamber cells of flare or hypopyon. We spoke about hypopyon. So here we see precipitates, hypopyon, and problems with pupil. Yes, here we see the non-round pupil. It can be pupil can be miost or constricted. It can be irregular, posterior synechiae. Here we see. So on the third picture, you see the posterior synechiae. It's the adhesion of iris to the lens capsule. From the iris, we can see rubeosis. Rubeosis is neovascularization of the iris, or can be nodules or granulomas in the iris. Intraocular pressure in this process can be normal, but can be elevated or depressed due to the how many time you go through the start of uveitis. Sometimes uveitis starts with elevated intraocular pressure, sometimes with depressed. The most popular inside of our organism processes which can cause the iridocyclitis. It is ankylosing spondylitis. Young male people mostly suffer from it. Arthritis can be here. Very useful information is about 90% positive HLA-B27. It can be acute, recurrent, and non-granulomatosis anterior uveitis, mostly with hypopyon. The next variant is juvenile idiopathic arthritis. It's idiopathic chronic arthritis, age under 16 years, mostly female, 80% positive for and About uveitis, it's bilateral, chronic, and non-granulomatoous. In this process can be complications such as cataract and bent keratopathy. Here we see the bent keratopathy. It's a pity that it's children. The next variant of uveitis is intermediate one or cyclitis. Symptoms are near to the iridocyclitis, but we don't see any signs on the cornea, very rare. So mostly it is headache and severe pain in the eye because of because the process is in the cellular body and a little bit deeper in the choroid. Mostly it's flutters and blurring vision as symptoms. About treatment of iridocyclitis and pars planitis. Mydriatic eye drops, of course, corticosteroids drops and combined drops with dexamethasone and hydrocortisone and sometimes with antibiotics. Non-steroidal eye drops, antibacterial drugs in iridocyclitis can be used if we know that it is a bacterial process. Antiviral drops and ointments, it's acyclovir or ocoferon, it's due to the hepatic process. Physiotherapy can be used too if we have in clinic these devices. In our clinic practice, we need to differentiate acute iridocyclitis and conjunctivitis. The degree of the injection of the eyeball and conjunctiva, of course, in case of acute iridocyclitis is bigger than in acute conjunctivitis. In acute iridocyclitis, we can see narrow pupil or changes in the pupil, such as adhesion to the capsule of the lens. We don't see here these changes in conjunctivitis simple. Presence of posterior cineae here and presence of changes in the endothelium of the cornea. It means that there are precipitates in iridocyclitis and we don't have precipitates in conjunctivitis. In acute iridocyclitis, we will not have any discharge in the conjunctival sac, but in conjunctivitis, we can see different variants of discharge in conjunctival sac. Posterior uveitis. Posterior uveitis, it's inflammation behind oris rata and inflammation of the choroid and retina. There are different variants of inflammation here. It can be retinitis, chororetinitis, retinal vasculitis. Also, etiology is etiology can be different from infection to different rheumatological diseases. Classification is very big and it's also depends on etiology, nature, and localization of the inflammatory process. Due to etiology, it can be endogenous and exogenous, the same. By nature, it can be focal and diffuse. Focal and diffuse. Focal, it means that there is little focus or big focus, but one or two focus. Diffuse, it can be process in a very big part of the choroid or chororetina or in the retina and choroid, and suffer a lot of tissue. By localization of the inflammatory process can be central. The focuses are in the central part of the fundus. Peripapillary, it means that the focus nearby the optical disc. Equatorial, focus in the area of the equator of the eye, the medial part of the fundus. And peripheral, focus in the peripheral parts of the fundus. So we can see it only with special lenses. Choroiditis, complaints, pain, photophobia, but about pain. If it is choroiditis only without the cyclitis, pain can be, we can have patient without any pain, but we will have photophobia, lacrimation, sorry, I start to explain, but I can read only. Pain, photophobia, lacrimation are absent. Of course, this are absent due to the fact that there are no any sensitive innervation in the choroid. We spoke about it in the anatomical lecture. There are no any sensitive innervation. Because of it, pain is absent here. But there is a reduction of the visual acuity, and the degree of reduction of the visual acuity depends on localization of the focus, and of course it will be very big if the focus is the central part of the fundus. The appearance of floaters, it is moving shadows in the field of vision, and it small exudates in the vitreous body, which gives some shadows to the retina. Also, maybe photopsy, we can find photopsine complaints. It's flickering in the front of the eye, or fear sparks, flashes, something like on the picture. Also, we can see metamorphopsia. If we have pathological focus in the central part or paracentral part, the shape of objects is distorted, and we can see spots, dark spots in the central part, or different variants of changing of the shape of the objects we see. Also, we can have positive scotoma detected by perimetry, and hemerolopia. We spoke about it in the function lecture. About clinical picture, at the beginning of the disease on the fundus there are grayish and yellowish white foci infiltrates. Then the focus become whitish gray more clearly. There is accumulation of the pigment, brown color nearby the focuses. In chronic course, inflammatory granulomatose of gray-green color may occur too, and could be hemorrhaging, mostly in acute period. About specific variants of choroiditis, toxoplasmosis variant. Toxoplasma gondii is an obligatory intracellular protozoan parasite, and due to iron, it can cause only the backside inflammatory processes. And choroiditis is a mostly common process caused by toxoplasma. It can be acquired and congenital. Toxoplasma give to the eye vitritis and retinitis. Active lesion, creamy white lesion with indistinct margins. And inactive lesion, white well-defined area of chorioretinal atrophy with pigmented borders. It's very specific variant of pathological focus due to toxoplasma. And specific treatment with antiprotozoal drugs, clindamycin, sulfonylamides, steroids, but now there are no very specific to toxoplasma treatments. It's a pity, but we use those variants which can help us a little bit in the acute period, of course, in the acute period. About panuveitis. About panuveitis, it's inflammation of the entire oral tract. It's iridocyclitis plus parsplanitis plus choroiditis. So the entire oral tract. Firstly, the most common variant of diseases which can cause the panuveitis is Behçet syndrome. There are different symptoms. It's gentle ulceration, ocular inflammation, skin lesions include erythema nodosum, folliculitis, and positive pathology test. Also, we have when we have all these variants or two of these variants of pathology, we can speak about the Behçet syndrome, and also this patient can be treated not only by ophthalmologist but mostly by a rheumatologist. Due to the eye, there are some ocular features. It's bilateral process, chronic with remissions and exacerbation. Non-granulomatous panuveitis may be only iridocyclitis, vitreitis, retinitis, or can be panuveitis. Also, we can see vasculitis, venous occlusion, and neovascularization of the fundus. The next disease which can cause panuveitis is Fox-Koyanagi Harada. It's multisystemic autoimmune disorder. Affect pigmented cells in the body, involved CNS, eyes, and skin. Due to the eye, it's a bilateral uveitis, multifocal cirrhosis detachment of the sensory retina, bilateral exudative retinal detachment. In the chronic stage, can be vitiligo of the fundus, the depigmentation of the fundus, or fox atrophic spots. Tuberculosis uveitis. It is granulomatous anterior uveitis mostly, focal, multifocal choroiditis and choroidal granulomas, retinal vasculitis. So inflammatory process mostly in the anterior part of the choroid, but vessels mostly suffer in the retina, in the backside. About treatment. Чему эта штука опять вылезла? Ага. Management of uveitis. Of course, we need to determine the etiology. We need to do some investigations. Due to drugs, we use steroids. It can be topical or systemic variants. Also, we use mydriatics, antimicrobial drugs, or specific antiviral drugs, if we spoke about herpetic variant of uveitis. Immunomodulators or immunosuppressive agents. We can use cyclosporin, methotrexate, and azathioprine, but these drugs we use together with rheumatologist. Very rare, we give the drugs only by our management, I mean by ophthalmological management. What about complications after uveitis? They observed in 20% of cases. It is atrophy of the pupil. Adhesion of the pupil range with the anterior lens capsule, which is accompanied by the violation of the outflow of intraocular fluid, resulting in secondary glaucoma. For example, here you can see the variant of Bambage. There is a total adhesion of the pupil range to the lens, to the capsule of the lens. So, as we know from the previous lecture, the aqueous humor is goes from the backside to the anterior to the anterior chamber through this pupil. So this pupil is closed. There is a intraocular fluid cannot go out. As a result, we have the gross intraocular pressure and secondary glaucoma. It's very serious complication. Also, we can have cataract. Cataract need surgery. Deformation of the vitreous and retinal detachment. Here we see retinal detachment. It's very strong complication too. And atrophy of the eyeball. Sorry about this. I will not see again. Okay, next. We speak about it on your practical lessons. And the last part of the lecture, but we need to know about it too. There are different ocular tumors, malignancies, and neoplasms. This on the slide, you see different cancer factors. It's common variant. It's not only for the eye, but for the cancer in common. So due to the eye, due to the choroid, there are different neoplasms, cancer in the eye, and you know that in the one of the layers of the retina and in the choroid too, there is pigment cells. So from pigment cells we can have a different, not different, but one of the severe variant of the cancer, it's melanoma. Before starting speech of melanoma, we need to speak about choroidal nevus. Choroidal nevus, it's non-malignant. It's it can present up to 30% of general population, and it can be on the skin and in the fundus too. It is flat or minimally elevated. It's less than 6 millimeters in diameter. It's melanotic or unmelanotic. It can be with or without melanin. There can be overlying drusen in it. Oh, then no, don't worry. We will end the lecture in these 10 minutes. Okay. Проблема. This in these pictures you can see different variants of choroidal nevus. It's not a melanoma, it's nevus. It's
benign.
non-malignant. Huh?
It's benign.
Mm-hmm. What about primary uveal tumors? It are unilateral or solitary. It elevated, relatively elevated. We can see it on the B scan. They can locate it anywhere, but they like the posterior polus, the posterior pole mostly, near the optical disc or, for example, the big melanoma. or in the central part can be too. Here on the optical coherent tomography, we can see the retinal detachment and the choroidal pigment process, malignant process. They can metastase, of course, as other malignant processes. Most frequent site of metastasis of eye cancer is to the liver. And there is some pictures of melanoma. They can be amelanotic or with melanin too. And mostly it combines with retinal detachment behind it. It is small melanoma. It's simply with nevus, but we need to know the anamnesis, we need to know the clinical history, and we need to know how it is look like the fundus. So due to all information, we can say that it is melanoma, but not the nevus. Also here it is a retinal detachment. Under it there is a melanoma, for example here. For tumors, what can we use? What treatment options we can use for tumors? It's brachytherapy, it's radioactive plaque. It's two surgeries when we give the radioactive plaque and then we take it out. Systemic radiation if there is a metastatic process, photocoagulation of the melanoma, cryotherapy, inoculation of the eye, and transpupillary thermal therapy. For example, here you can see the choroidal melanoma post-photocoagulation therapy. These white spots is photocoagulation of the tissue of melanoma. Very big melanoma. And this variant, it's after brachytherapy with atrophy. This big melanoma too. It's on the B scan. It's a part of melanoma near the optic disc. It's the central part, very big. Not only the choroid in the backside melanomas can be, it can be in the iris. Also it is malignant process. It can be differentiated with neurolymphoma, phantomgranuloma, nevus, iris cyst, leaf nodule, and melanotostoma. If there is a process more than 3 mm diameter, increased IOP intraocular pressure, distorted pupil, rapid growth, secondary cataract, so it's malignant process. Maybe. For example, amelanotic iris melanoma. It's melanoma without pigment. It's very big in the anterior chamber, close the way to go to of the aqueous humor, so there is an increased IOP. It's problema. It's after operation, for example, and here we see the complicated cataract. It is melanoma with pigment and with neovascularization. Oh,